Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a man of 54 years of age, obese and smoker, without other classic cardiovascular risk factors or backgrounds of interest. He arrives at our unit with the diagnosis of STEMI of approximately 6 hours of evolution. His clinical situation is stable, but chest pain persists. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it. In this electrocardiogram, we have these alterations. First, ST segment elevation of the inferior leads, 2, 3, and ABF, emphasizing that ST is taller on 3 than on 2. Second, ST segment descent on high lateral leads, 1 and AVL. And third, image mirror descent of the ST on V1, V3, and V2. This means that we have an acute myocardial lesion of subepicardial or transmural characteristics on the inferolateral region of the left ventricle, which translates into an inferior STEMI. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, primary angioplasty was performed. As you can see, left coronary tree has no significant lesions angiographically. However, left coronarography shows an interesting finding. Can you see it? That's it. It is the right coronary artery whose distal bed is visible thanks to the existence of heterocoronary collateral circulation. This suggests that the right coronary artery is probably closed, which would explain the ST segment elevation on inferior leads of the electrocardiogram. Let's take a look. As you can see, there is a complete blockage of the middle segment of the right coronary artery. It is important to point out that the origin of the acute marginal branches is proximal regarding the occlusion, so the irrigation of the right ventricle is probably not compromised, and because of it, elevation of the ST segment on right precordial leads does not exist. Now we know where the obstruction is and we only need to treat it. First thing to do is to pass an angioplasty guide wire through the closure. Sometimes, as in this case, passing the guide wire partially opens the artery and allows us to see part of the distal bed. In this case, the next step was to implant a stent on the blockage zone. This props the artery and returns blood flow. And this is the final result. As you can see, we have recovered the blood flow of the artery after implanting the stent, obtaining a good angiographic outcome and without pre-procedure complications. In this way, with the artery open, the ST alterations are progressively improving and pain disappears, being this emergency resolved, and with it, our chapter. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!